Module 2 Economic Evaluation, Priority Setting, and Health Policy Interface. 1. Introduction to Economic Evaluation in Health Economics. One of the most practical tools in health economics is economic evaluation. This is the process of comparing the cost and outcomes of different health interventions to determine which gives the best value for money. In a world of limited resources, decision-makers face constant trade-offs. Should a country invest in a new cancer treatment or a vaccination program? Should a hospital buy a new MRI machine or hire more nurses? Should public health budgets focus on prevention or treatment? Economic evaluation provides a systematic, evidence-based approach to answer these questions. 2. The purpose of economic evaluation. Economic evaluation is not about being cheap, it's about being efficient. Efficiency in economics has two main forms. Technical efficiency, producing a given health outcome at the lowest possible cost. Allocative efficiency, allocating resources to produce the combination of health outcomes that society values most. Without economic evaluation, health spending can become inefficient, with money flowing to interventions that have less benefit compared to cheaper alternatives. 3. The main types of economic evaluation. A. Cost minimization analysis, CMA. Used when two or more interventions produce identical outcomes. The decision is based purely on cost. Example, choosing between two equally effective generic drugs, pick the cheaper one. B. Cost-effectiveness analysis, CA. Compares interventions with the same type of outcome, e.g., years of life gained. The result is expressed as a cost per unit of outcome, e.g., cost per life year saved. Example, comparing two screening programs for early cancer detection. C. Cost-utility analysis, CUA. Similar to CA, but outcomes are measured in terms that capture both quantity and quality of life. The most common measure is QALYs, quality-adjusted life years. Example, comparing hip replacement surgery versus drug therapy for arthritis, where quality of life matters as much as survival. D. Cost-benefit analysis, CBA. Both cost and benefits are expressed in monetary terms. The intervention with the highest net benefit, benefits minus cost, is preferred. Example, comparing the monetary value of lives saved in road safety programs with the cost of implementing them. E. Cost-consequence analysis, CCA. Presents cost alongside multiple different outcomes without aggregating them into a single measure. Useful when decision-makers want to see the full range of impacts. 4. Steps in conducting an economic evaluation. Define the decision problem. What choices are we comparing? Who is affected? Choose the perspective. Would the analysis be from the health system's perspective, the patient's perspective, or society's perspective? Identify the alternatives. What are the interventions under consideration? Measure costs. Include direct, indirect, and intangible costs. Measure outcomes. Use relevant health outcome metrics, life years gained, QALYs, DALYs, etc. Discount future costs and benefits. Because money and benefits today are worth more than in the future, economists discount future values. Perform sensitivity analysis. Test how results change if assumptions or estimates vary. Interpret and present results. Provide clear, transparent conclusions for decision makers. 5. Setting priorities in healthcare using economics. Once we know the cost and outcomes of interventions, the next step is priority setting, deciding which programs to fund. Because demand for healthcare always exceeds supply, priority setting ensures that limited budgets achieve the greatest possible health gain. Priority setting approaches. A. Explicit priority setting. Uses formal criteria like cost-effectiveness thresholds, burden of disease, and equity considerations. Example, the UK's National Institute for Health and Care Excellence, NICE, often uses a cost-effectiveness threshold of £20,000 to £30,000 per QALY gained. B. Implicit priority setting. Decisions are made case by case without clear, public criteria. This can lead to inconsistency and potential bias. C. Program budgeting and marginal analysis, PBMA. Involves reallocating resources from less effective programs to more effective ones. D. Multi-criteria decision analysis, MCDA. Considers multiple factors, cost-effectiveness, equity, feasibility, patient preferences, and weights them. Equity versus efficiency. A recurring challenge in priority setting is balancing efficiency, maximizing health gain for resources used. Equity, ensuring fair access and addressing inequalities. For example, a rural health clinic might be less cost-effective than an urban hospital in terms of patients served per dollar spent, but equity considerations might justify funding it to ensure rural populations are not excluded. 6. The interface between health economics and health policy. Health economics doesn't exist in a vacuum, it directly informs health policy. How health economics influences policy. Evidence for decision-making. Economic evaluations help policymakers choose which treatments, technologies, and programs to fund. Budget planning helps determine how much should be allocated to health and within health to various programs. Regulation and pricing. Health economics informs drug pricing, hospital payment systems, and physician compensation. Insurance design guides how insurance schemes are structured to balance coverage, costs, and incentives. Challenges in applying health economics to policy. Political pressures. Politicians may fund popular programs even if they are not cost-effective. Ethical concerns. Sometimes the most efficient choice conflicts with moral obligations. Data limitations. Economic evaluations require reliable data, which may be lacking in low-resource settings. Public understanding. Complex cost-effectiveness arguments can be hard to explain to the public. 7. Real-world case studies. Let's bring this to life with a few examples. Case Study 1. HIV treatment in Africa. In the early 2000s, HIV antiretroviral therapy was extremely costly. Economic evaluations showed that mass treatment was not only life-saving but also cost-effective because it reduced hospitalizations and allowed people to return to work. This evidence helped secure global funding through programs like PEPFAR and the Global Fund. Case Study 2. HPV vaccination. Cost-effectiveness analysis showed that vaccinating adolescent girls against human papillomavirus would prevent cervical cancer at a relatively low cost per kilo gained. This influenced national immunization schedules worldwide. Case Study 3. Dialysis in the UK. In the UK, NICE reviewed the cost-effectiveness of dialysis for end-stage renal disease and established guidelines that balanced cost, quality of life, and patient survival. 8. The future of health economics. Emerging trends will shape the future of health economics. Precision medicine, tailoring treatments to individuals raises questions about affordability. Digital health, telemedicine, health apps, and AI diagnostics require new evaluation methods. Aging populations, longer lifespans increase demand for chronic disease management. Global health threats, pandemics and climate change create new economic challenges for health systems. 9. Conclusion and key takeaways. From Module 1 and Module 2, here's what we've learned. Health economics helps allocate scarce resources efficiently and fairly. Health and healthcare are related but not identical, social determinants matter. Economic evaluation is a core tool for comparing health interventions. Priority setting must balance efficiency with equity. Health economics directly influences health policy, but politics, ethics, and public opinion also play roles. The future of health economics will need to address emerging technologies, demographic changes, and global health risks.